I'll be talking about oncologic emergencies today. Onc emergencies are defined as any acute, potentially morbid, or life-threatening event directly or indirectly related to a patient's tumor or its treatment. And it's usually, onc emergencies are usually classified by system of dysfunction, which we'll get into on the next slide. It's important to note that sometimes these oncologic emergencies can be the presenting symptom for a patient who has undiagnosed cancer. And these emergencies can occur in patients with early or metastatic disease. So today we'll talk about onc emergencies in three main categories being structural, metabolic, or chemotherapy related. So the structural emergencies we'll talk about are superior vena cava syndrome, or SVC syndrome, spinal cord compression, and the metabolic ones we'll discuss are tumor lysis syndrome and hypercalcemia, the malignancy. We will not be talking about SIADH. And then under the chemotherapy-related emergencies, we'll discuss infiltration and extravasation, and allergic and anaphylactic reactions to chemotherapy. And then we'll touch briefly on febrile neutropenia, although we won't go into much depth because I believe you get a separate ID lecture as it pertains to this topic. So we'll begin with the case. We'll talk about a 67-year-old man who presents to the ER with shortness of breath, cough, and fatigue. He noted that his symptoms have been present for about 2 weeks, but they acutely worsened over the last 24 hours, which caused him to go into the emergency department. His past medical history is significant for hypertension, diabetes, and DJD. Of note, he does have a 40-pack year smoking history, is a current smoker. On review of systems, he knows that he's had a 15-pound weight loss for the past 2 months, and his family has noted that his face and neck were quote-unquote swollen. So you examine him, and he's afebrile. His respiration rates are 20. He's noted to be setting 86% on room air and 95% on tube liters. Then you notice that he has distended neck veins that are unchanged with positional changes, and he has decreased breath sounds on the right with dullness to percussion, and the vessels in his chest are visibly distended. He looks much like this man right here. So this is an example of a case presentation of a patient with SVC syndrome. So with SVC syndrome, primary intrathoracic malignancies account for about 90% of the cases caused by malignancy. Although most of the cases now are more commonly caused by non-malignant causes, mainly thrombosis and access catheters. So that's about 20 to 40% of cases now. But back to the cases caused by malignancy, the most common cancers to cause SVC syndrome are the lung cancers and lymphoma. Now, those are the most common primary causes of SVC. Other malignancies, such as breast and testicular, when they metastasize, can also cause SVC syndrome. Other non-malignant causes of SVC syndrome include thymoma, goiter, sarcoid, and radiation, particularly patients who have had radiation several years prior, and they could have fibrosis. SVC syndrome is caused by the direct invasion of tumor into the SVC. It can be also known to be caused by extrinsic compression and obstruction of the SVC by a mass, namely a malignant mass. SVC syndrome can lead to thrombus formation. And then as such, blood flow is obstructed, and most patients, depending on when they are diagnosed, can already have the venous collateral formation. This may develop quickly, particularly if it's from a tumor that is sort of highly proliferative, on the order of days to weeks. Common signs and symptoms of SVC syndrome include face and neck swelling, distended neck veins, and upper extremity swelling. Other common signs and symptoms include cough, dyspnea, orthopnea, and distended chest vein collaterals or conjunctival suffusions, which are redness of the conjunctiva that's not caused by like conjunctivitis or inflammation. Less common are those listed here on the right side of the screen. They can include stridor, hoarseness, dysphagia, pleural effusions. If pleural effusions occur, they're mainly on the right side. Head plethora, headache, nausea, lightheadedness, or syncope, changes in vision. And in severe cases, altered mental status or coma. In order to treat SVC syndrome, in order to diagnose SVC syndrome, we usually acquire a CT or an MRI. In addition, Dopplers may be helpful when going through the workup, as you can investigate or evaluate for thrombus formation in the subclavian, axillary, or brachiocephalic veins. In addition, if when you get imaging, you know the patient has a tumor that is the cause of the SVC syndrome, this can help with further diagnosis of the malignancy and help guide where to get a biopsy. This all becomes important because the treatment of SVC syndrome largely depends on how severe the patient's symptoms are and what is the cause of the SVC syndrome. So generally, treatment for SVC syndrome can include definitive chemoradiation or radiation, depending on the histology of the tumor type that's causing the SVC syndrome. In patients who have life-threatening SVC syndrome symptoms, then endovascular stenting is used to reestablish blood flow. In some cases, thrombolytics are needed if there's a thrombus causing it. In some instances, people have used other medications such as diuretics and steroids, although the evidence for their efficacy is largely lacking, but they may help with some of the symptoms from the SVC syndrome. So, when patients have life-threatening symptoms from the SVC syndrome, this would be an indication for stenting. Life-threatening symptoms can include airway obstruction, severe laryngeal edema, coma, and cerebral edema. Of course, before stenting, one would secure the patient's airway. Another indication to stent is if the tumor that is causing the SVC syndrome is not particularly sensitive to chemotherapy or radiation, such that if you were to use those methods to treat the cancer, the SVC syndrome would not be treated. In addition, if patients' SVC syndrome is related to radiation-induced fibrosis, that would be another reason to stent. Also, of course, stenting can be important for the palliation of symptoms related to SVC syndrome, and particularly in patients who have a tumor malignancy causing the SVC syndrome, but they are of poor performance status to tolerate the urgent systemic therapy or radiation for that tumor. SVC syndrome stenting on a whole has a low sort of incidence of complications related to the stenting, complications being mainly bleeding and hematoma. And the mortality rate for the procedure is somewhere around 3%. Now, once a patient has had the stenting, there is no sort of consensus regarding duration of post-procedural anticoagulation. And so there's different sort of recommendations regarding if patients need post-procedural AC versus post-procedural antiplatelet therapy. But I can tell you in clinical experience, most of my patients with SVC syndrome from their masses have also unfortunately had blood clots, and so they are on indefinite anticoagulation anyway. So when a patient has SVC syndrome, it's important to get the diagnosis, namely if the etiology is from a malignant cause or non-malignant cause. And it's important to assess if the patient's symptoms are life-threatening, necessitating urgent stent placement, versus if their symptoms are not life-threatening, you have time, particularly if the etiology is from a tumor, to go forth with the diagnostic workup, including a biopsy and getting the histology of the tumor in order to determine the best treatment for that patient. Naturally, if a tumor is present when the patient presents with SVC syndrome, it is always appropriate to consult medical oncology if they can help guide the diagnosis and treatment. So moving on next to another case. This one is a 62-year-old woman who comes to clinic noting progressive back pain for 2 weeks that acutely worsened over the past 24 hours. She has a history of a 2010 renal cell cancer. She had a nephrectomy, and she had been following with serial scans since that time. She has really no significant past medical history, and her review of symptoms is largely negative. On physical exam, her vitals are all fine. But she is noted to have on her neurologic exam 3 out of 5 strength in the lower extremity and changes in reflexes. So this is an example of a case of a patient presenting to the ED with concern for spinal cord compression. On a whole, spinal cord compression is associated with a poor prognosis, with a median survival of about 6 months after diagnosis, although this is largely dependent upon the histology of the underlying cancer, which is causing the cord compression. So cord compression is caused by a tumor compressing the dural sac, which this initially causes edema and venous congestion and demyelination. And prolonged compression leads to vascular injury, cord necrosis, and permanent damage. The tumor involvement is usually of the anterior vertebrae, and there's occasionally mets to the epidural space. On a whole, spinal cord compression occurs in about 1 to 5% of patients with cancer. It's important to note that early diagnosis is key to regaining strength. So cord compression can result in paralysis if treatment is delayed. And patients typically with no neurologic function for greater than 48 hours are unlikely to improve. So for this one, it's particularly important to act as soon as the level of suspicion is there. So most of the cases of spinal cord compression involve the thoracic spine, although 20% of cases is the LS spine and 10% is cervical. The most common cancers associated with spinal cord compression are from the lung, breast, prostate, renal, and unknown primary. How can one recognize if a patient has spinal cord compression? Particularly if a patient, has a known diagnosis of cancer. The most common early first symptom is pain. And this pain may be worse when laying down and also pain with percussion of vertebral bodies. This pain can precede the nervous symptoms by months. Now, weakness with sensory loss below the involved cord can also be a sign or symptom. It's most common to have motor deficits. And unfortunately, the late signs and symptoms include autonomic dysfunction and urinary or fecal retention or incontinence. And these late signs and symptoms are often associated with paraplegia. And so with most oncologic emergencies, it's best to sort of think about this early and treat early because the best chance of avoiding paralysis is treating early. In order to make the diagnosis, of course, patients will have a careful neural exam, and the MRI is the gold standard. We would order a whole spine MRI to evaluate for all sites of disease. Of course, if patients have a contraindication to getting MRI with gadolinium, then a CT scan can also be acquired. So with cord compression, our main goals are to improve pain, but also to improve neurologic function. So oftentimes when patients come in with cord compression seen on imaging, it's important to start high-dose steroids initially with Decadron. And then there becomes a decision tree about if the patient will benefit from surgery and radiation or radiation alone. So it's best when patients come in, they are diagnosed with cord compression, to consult both neurosurgery and radiation oncology to help determine the best treatment for the patient. On a whole, patients who are fit, don't have a lot of comorbidities, have a great performance status, and a life expectancy greater than 3 months are better served by having their cord compression treated with surgery followed by radiation versus radiation alone. There was a study looking at the difference between surgery and radiation followed by radiation alone, with the primary endpoint of a patient's ability to walk 4 weeks after therapy. And as you can see, patients who were treated with surgery and radiation were more likely to be able to walk 4 weeks post-op compared to, or 4 weeks post-treatment rather, compared to the group of patients who received radiation alone. Also, the group that received radiation and surgery received radiation then surgery, who were able to walk for a longer duration compared to patients who received radiation alone. And there was higher rates of continence and better muscle strength and functionality in the surgery group compared to those who just had radiation alone. Now, if a patient has a sort of poor performance status, they're not going to be able to get more treatment for their underlying malignancy. They have a life expectancy of less than 3 months, and typically radiation is offered as a palliative means to try and preserve as much quality of life for those patients. So with patients with cord compression, it's important to recognize it early. We know that the patient walks in is the patient that walks out. Patients who have neurologic compromise for greater than 48 hours are unlikely to regain that neurologic function no matter what treatment they receive. And for patients who have cord compression, it's important to start high-dose steroids, to consult neurosurgery and radiation oncology for the primary treatment. And of course, always consult medical oncology to help with the sort of decision tree or decision-making process, particularly if the patient has no known diagnosis of cancer and this is their presenting symptom. Moving on now to metabolic emergencies. We'll first talk about tumor lysis syndrome. Tumor lysis syndrome is the most common oncologic emergency, and this, is important to note, can occur spontaneously or with chemotherapy or radiation therapy or biologic therapy. And now we are using more sort of biologics in the treatment of cancer, so it's important to remember that. Also important to note is the time frame with which we would expect tumor lysis syndrome to occur, which is typically 3 days before through 7 days after treatment. Tumor lysis syndrome results from rapid acute cell lysis caused by cancer treatment. On lab evaluation, you can see hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, azodemia, and acute renal failure. If left untreated and unrecognized, this can lead to end organ damage, particularly AKI, and renal damage such that patients may require dialysis, fatal arrhythmia from the hyperkalemia, which can ultimately lead to death. So what's important with tumor lysis syndrome is to try and prevent it. When patients who have known malignancy are going to be treated with their systemic therapy, it's important to kind of assess what is the patient's risk factor for the development of tumor lysis syndrome. On a whole, patients with hematologic malignancies, the leukemias and lymphomas, are at a higher risk for tumor lysis syndrome compared to the solid tumors in the sort of more indolent lymphomas. Also, patients at risk include those with tumors with a high proliferation rate and tumors with high sensitivity to chemotherapy. These can include patients with testicular malignancies. And of course, Patients with already pre-existing renal disease or impairment may be at risk for the development of tumor lysis syndrome. So it's important to watch those patients carefully in the correct clinical situation. So tumor lysis syndrome results from the release of intracellular products such as uric acid, phosphates, calcium, potassium that overwhelms the body's homeostasis. And compensatory responses of the kidney are exhausted as a result of the massive release of ions and the rapid turnover of cells, which leads to an overwhelming production of uric acid. This uric acid can crystallize in the renal tubules and cause obstructive neuropathy and can result in renal damage. So, our best defense is to prevent this as possible. But in order to sort of work up a patient where we're concerned that has tumor lysis syndrome, we may have a heightened sense of awareness if a patient says they have nausea, vomiting, diarrhea, lethargy, muscle cramps, tetany, or hematuria. Of course, on lab work, we would be getting a CBC, CMP, checking the electrolytes, uric acid, and the diagnosis can be made either based on laboratory data or a clinical diagnosis. For the laboratory diagnosis, we use the Cairo-Bishop criteria, which states you need 2 or more criteria in the same 24-hour period in the correct time interval, 3 days before treatment through 7 days after initiation of chemotherapy. It involves having a uric acid that is 25% increase from baseline or greater than 8, a potassium, which is 25 increase from baseline or greater than 6, a phosphorus, which is 25% increase from baseline or greater than 0.5, and a calcium, 25% increase from baseline or less than 7. The clinical diagnosis of tumor lysis syndrome can be made with laboratory data consistent with tumor lysis syndrome and 1 or more of these clinical criteria, including seizure, cardiac arrhythmia, sudden death, and creatinine greater than 1.5. We, of course, do not want to wait for these clinical signs and symptoms of tumor lysis syndrome before we act. So, as I've been saying with most of these oncologic emergencies, our sort of best defense in all of them, if possible, is prevention. So how can we try and prevent tumor lysis syndrome? First, of course, we assess a patient's risk. What malignancy do they have? How proliferative is it? How sensitive is the tumor? This will give us an idea of the risk of tumor lysis syndrome and if we need to enact any sort of preventive measures. Some preventive measures we can enact is to start aggressive hydration before a patient starts treatment. Of course, naturally, we would want to avoid any NSAIDs or contrast agents or things that will be nephrotoxic to the kidney. Now, another agent we have for prevention is allopurinol. So when patients get hyperuricemia because of tumor lysis, it's a consequence of the catabolism of peri-nucleic acids to xanthine and then to uric acid. And this all happens because of the xanthine oxidase protein. So allopurinol inhibits the xanthine oxidase and thereby blocks metabolism of xanthine to uric acid and decreases uric acid production. So in patients who are at sort of moderate risk to getting tumor lysis syndrome in addition to fluids, we would start allopurinol at a dose of 100 to 300 milligrams QD to try and decrease the risk of a patient having tumor lysis syndrome. And any medication you use, of course, there's always potential side effects, and this would be a risk-benefit discussion and decision. But with allopurinol, patients can be at risk for allopurinol hypersensitivity syndrome, which is manifested with a rash, eosinophilia, and acute hepatitis. In addition, it's important to remember that there's a significant interaction with allopurinol and the azothioprine. Oh, sorry, some technical issues there. So along the same lines of prevention, using IVF, it can take about 3 to 5 liters a day to ensure patients are well hydrated, their kidneys are well hydrated, so you won't run into renal trouble. Now, in patients who are at risk for tumor lysis syndrome or we're suspecting tumor lysis syndrome, we typically recommend monitoring the tumor lysis syndrome labs every 6 hours initially. This is usually for the first couple of days, and then once a patient's lab indices stabilize and they're sort of out of the more acute concern for tumor lysis syndrome, then this can be titrated down back to daily. For patients who we have a strong suspicion, based on the lab data, that they are approaching tumor lysis syndrome, we can also give respiricase. This is typically given for patients with a uric acid greater than 8, in addition to the other labs, which would be reflective of the patient with tumor lysis syndrome. In patients who do not respond either to the preventive measures, using the allopurinol prevention, or getting the respiricase, that they sometimes will need hemodialysis. So in patients whose creatinine is increased, particularly if their electrolytes are very much disturbed, like hypercalcemia, it's important to consult nephrology early. So in case a patient needs urgent hemodialysis, they're able to receive it. Just a little note on respiricase, which we typically give if the uric acid is greater than 6. It's a recombinant uricase enzyme that's derived from the Aspergillus, and it's approved for the prevention and treatment of tumor lysis syndrome in patients receiving chemotherapy for hematologic malignancies. What's important to note about this is that respiricase can cause severe methylglobinemia or hemolytic anemia in patients with glucose 6-phosphate dehydrogenase deficiency, or G6PD. So in assessing a patient's overall risk for tumor lysis syndrome versus the risk for its hemolytic anemia for G6PD deficiency, most of the time you will not know if a patient has G6PD deficiency, particularly if they're presenting to the ED with these electrolyte abnormalities in the setting of recently receiving chemotherapy. And so then you would need to sort of assess the patient's risk of having G6PD. So it's important to remember the genetics of that. So this G6PD is X-linked recessive. And so males will have all of their red blood cells affected. For females, because it's X-linked recessive, they would have half normal RBCs and half would be unaffected. Usually, women are usually unaffected carriers of G6PD. If you look directly at the respiricase label, there is a black box warning as it relates to the G6PD deficiency for respiricase causing hemolysis in those patients and the risk of anaphylaxis. But with anything, it's risk-benefit for ensuring that we're treating the tumor lysis syndrome. Moving on to hypercalcemia of malignancy. This is the most common electrolyte derangement in about 10 to 20% of patients with malignancy. And the cancers most likely to cause hypercalcemia include myeloma, lung cancers, and renal cancers. The etiology may be due to several things. One, the tumor secretion of parathyroid hormone related protein, which about 80% of cases could be the result of bone mets with osteoclast activation and release of cytokines, or a result of tumor production of vitamin D. This mainly happens in lymphomas. Common signs and symptoms of hypercalcemia of the malignancy include dehydration, anorexia, and fatigue, nausea, vomiting, constipation, and ileus, bradycardia and a short QT interval, polyuria and nephrocalcinosis, and weakness or mental status changes and seizure. Like with any oncologic emergency, the key is to have a sort of high level of suspicion in patients with those symptoms who have a known malignancy or a history of malignancy. If a patient is symptomatic, particularly with some of the more worrisome symptoms we noted on the previous slide, or if their calcium is greater than 12, they're usually treated as an inpatient. And it's important to focus on the corrected calcium because sometimes patients with malignancy, their calcium may not look to be that bad, however, their albumin can be very low. And so if we don't look at the corrected calcium, we may miss that the patient has hypercalcemia and that the hypercalcemia is the cause of their symptoms. So how do we treat hypercalcemia malignancy? With a volume expansion, so it could require a large sort of volume of normal saline. In the more sort of acute setting, if you have to bring the calcium down rather quickly, then calcitonin can be used, and its effect is evident in about 4 to 6 hours. This can be repeated on the order of 6 to 12 hours, but tachyphylaxis can occur after 24 to 48 hours. Typically, if you have to use that, you try to get a bisphosphonate on board as soon as possible. This will take longer to work, on the order of 2 to 4 days. And there's evidence that zoledronic acid is superior over pamindronate or another bisphosphonate. The dose of Zometa or zoledronic acid is 4 milligrams over 15 to 30 minutes. Now, depending on what is available at the hospital and what's on formulary, either zoledronic acid or pamindronate can be used. Denosumab can also be used, particularly if the patient has some renal dysfunction or some contraindication to receiving the zoledronic acid. As with anything, there are side effects with medication, so the bisphosphonates. The sort of most common side effect is a flu-like symptom with the first dose. Clinically, it doesn't typically happen with subsequent doses, and rare, although a real problem, is osteonecrosis of the jaw, which can happen in about 1% of cases. Fortunately, there's no cure for osteonecrosis of the jaw. It can only be treated locally or with systemic antibiotics. And if all of these measures do not work, then hemodialysis is also available if necessary. So if anything, you're having issues trying to bring the calcium down, it's very appropriate to consult teams for help. You can consult medical oncology, endocrinology, and nephrology, particularly if the renal indices are trending in the wrong direction. Moving on to chemotherapy-related emergencies, we'll first touch on infiltration and extravasation, and we won't spend a lot of time because the majority of you won't ever have to come into contact with these types of injuries. But when we use chemotherapies, they're classified as either irritants or vesicants. And irritants can cause inflammation or phlebitis at the site meaning where the IV is going into the arm. If there's extravasation, it can cause warmth and erythema and tenderness there. And typically, drugs that are classified, chemotherapy drugs classified as irritants, will cause these symptoms for a short duration. Now, with vesicant drugs or vesicant chemotherapy drugs, they will cause all of the above: inflammation, phlebitis, warmth, erythema, tenderness. But these drugs can have cause for full thickness necrosis and permanent damage. Here's a picture of some extravasation injuries from vesicants. So as you can see, it can cause some real sort of problems. Just for sort of general knowledge, with the chemotherapy agents that we use, the drugs that are considered irritants include the platinum agents, cyclophosphamide, bleomycin, and etoposide. The vesicant agents are considered to be azithromycin, vinblastine, vincristine, and rarely, in certain situations, taxanes and also platinums can cause damage similar to a vesicant. How do we treat this? Well, the nurses are well versed when patients are getting infusions of chemotherapy in the infusion center to monitor for sort of the signs of extravasation. They typically stop the infusion, remove the needle, and elevate the arm. They typically would also, depending on the chemotherapy that's causing the issue, alternate having cold packs on and off. And they alternate because it's felt that the cold, which promotes vasoconstriction, may clear the vesicant more quickly. For some drugs, heat packs are used because preclinical data has suggested that vasodilation works better to clear these particular drugs. There's also drugs which may be helpful, including steroids, hyaluronidase for the beta-alkaloid chemotherapies, and VMSO. Although the data on the use and also the appropriate dose of these medications is not well elucidated. I think what's very important is if you have a patient that's having this extravasation, particularly with a vesicant agent, that you consult plastic surgery to see if any type of debridement will be necessary. As with any onc emergency, our primary aim is to prevent. So we want to avoid, if possible, and anticipate when patients are getting infusions to ensure that this does not happen. Along a similar line for patients receiving chemotherapy, some chemotherapies have a higher risk than others of causing allergic or anaphylactic reactions. So the most common drugs associated with allergic or anaphylactic reactions include the taxanes, monoclonal antibodies, and platinum agents. These reactions typically occur within 30 minutes to 120 minutes post-initiation. But I can tell you from clinical experience, my patients that have had reactions from the taxanes can have it in as little as a few minutes of receiving the medication. The majority of these reactions occur within the first or second exposure of the chemotherapy drug. So we classify the reactions based on mild, moderate, or severe. Mild reactions can include flushing, itching, nausea, vomiting. The patients have stable vital signs. Moderate reactions include hives, chest pain, shortness of breath, angioedema, and patients may have low blood pressure. And severe reactions, patients can have any derivation of the above, but critical vital signs. The treatment largely depends on if this is a mild to moderate reaction or severe reaction. For all reactions, we would stop the infusion, give supplemental oxygen, give Benadryl, methylprednisolone, and nebs, epinephrine, and Zantac as needed depending on the severity of the mild or moderate reaction. For severe reactions, of course, we always stop the infusion, call with codeine or a respiratory code. I don't know the proper terminology actually here. Give oxygen, nebs, epinephrine, and retreat like an anaphylactic reaction. Like I said, on the whole, the majority of y'all will never have to come into contact with this unless you're in the ED or are working on the protein. So lastly, we'll just briefly touch on febrile neutropenia because as residents and fellows, you may see our patients who with malignancy recently received chemotherapy and are coming in with this. So the definition of febrile neutropenia is patients who have an oral temperature greater than should be 38.8, should be 38.0, or temperature greater than 100.4 degrees Fahrenheit for greater than 1 hour. In the setting of having an absolute neutrophil count of less than 1,000, with expected decline to less than 500 within the next 2 days. Or patients may have already a neutrophil count less than 500. So when patients have febrile neutropenia, it's important to get CBC to check the white count. So with chemotherapies, all chemotherapies have a nadir when we expect their white count to be the lowest. And so, when a patient gets a fever in that sort of nadir period, we have a heightened sense of awareness or suspicion that the patient has neutropenic fever. So you would get lab work to check what the neutrophil count is, a CMP to check, of course, organ function, and then blood cultures including bacterial and fungal, and then a urine analysis and a urine culture. Other infectious workup includes assessing catheters if the patient has an indwelling line, a port or PIC or urinary catheter, and then ordering necessary imaging as needed, namely CT scans of the chest if there's a cough, concern for pneumonia, that type of thing. Most important for patients with febrile neutropenia is to start empiric antibiotics as soon as possible. The IDSA guidelines recommend starting with 1 hour of patient presentation. And patients will be on these empiric antibiotics. I put 48 to 72 hours, but it could be longer depending on the clinical situation. But for patients who will be treated with empiric antibiotics, they need to, of course, be started on broad-spectrum antibiotics with an anti-pseudomonal beta-lactam, which could either be cefepime, carbapenem, or a piptazo. Vancomycin you can add if a patient has hemodynamic instability, a suspected catheter infection, a skin or soft tissue infection, pneumonia, or if patient's previous culture data suggest that they'd be at increased risk of an organism that would necessitate treatment with vancomycin. How long do we continue the empiric antibiotics? If there's no positive culture data, then the antibiotics are usually continued until clear signs of marrow recovery, which can be on the order of 48 to 72 hours or longer, depending on when the patient presents with the neutropenic fever. Of course, if there is positive blood culture, urine culture data, duration of the antibiotic treatment would depend largely on the organism that that grows and what site is causing the infection. As always, if there's any questions regarding the management of a patient with febrile neutropenia, then it is perfectly appropriate to consult the infectious disease team, and if it's and also the HEMONC service could also help one of our patients with malignancy. Take home for these onc emergencies is that the treatment requires the diagnosis. So you need to have the appropriate level of suspicion for these onc emergencies, particularly in patients who have a known history of malignancy. And with all of these onc emergencies, prevention is key. But if we can't prevent, an early diagnosis predicts for a better